Hello, my name is Patrice Brolsky, and along with Kate Shamzad, we will be hosting the webinar to both educate you and showcase the benchmarking platform, a new tool for child life. The Child Life Professional Data Center, or CLPDC, is going to be the location where child life professionals will be able to log both program activity and information, as well as productivity data about child life specialists. This webinar has a number of objectives, and hopefully they will help to organize the information that's presented and allow you to consider each phase of the development of the benchmarking platform. It is important to understand a brief history of the survey questions and the work done by many child life professionals over the course of a number of years to arrive at the data points that are involved in the platform. It is also important to understand the role of published research and evidence-based practice in the current platform that child life professionals will be working within. In addition to that, the webinar is going to take a couple moments to really acknowledge how this might be a brand new process for many child life programs across ACLP, or some programs, this might be an easy added data point to collect. Regardless of what it's like for your program, it is very important, as we know, to acknowledge and understand how changes in expectations can affect staff and their buy-in for a new effort. The webinar is also going to introduce viewers to the new platform for ACLP and the process of data collection. And to close the webinar, we're going to talk about how participants can gain support and the process for what the platform can look like in the future. To begin, it is really important to understand and acknowledge the hard work of many committee and subcommittee members over the course of time to put us in the position to be able to launch the Association for Child Life Professionals Data Center. A number of committees were combined under the concept of a mega committee. You might have known the mega committee as the research committee. At the close of 2016, after that board meeting. And there were a number of committees that were working and had similar themes and potentially some overlapping goals and objectives. And thus, bringing them together created a seamless process for excellent communication and collaboration. And so the three subcommittees that make up the mega committee, called the Scientific Advancement of Professional Practice Committee, is the Research Proposal Subcommittee, the Education Outreach and Awareness Subcommittee, and the Benchmarking and Database Subcommittee. And this slide has not only those titles, but also the charges for each one of the subcommittees. What is important to acknowledge as well is that both the Research Proposal and the Education and Outreach subcommittees accepted an additional request in the summer of 2016. And the request was for them to search published research as well as evidence-based practice related to current child life practice and new and innovative practices in our programs, to really scour the landscape to see what elements we could learn that would inform the survey questions, and also to address some of the things that we knew we needed to do differently post the work of the Patient Ratio Task Force. All three of these subcommittees fall under the leadership of the steering committee for the SAPP. And on behalf of all of the people who have worked so hard in this effort, we are grateful for that collaboration and contributions to this effort. So a brief touch point on what has been happening in the past. How did child life programs tell their story? What kinds of data is important to child life program leaders? And what do we do now to be able to advocate for program expansion and program development? Primarily, we do tell our stories through anecdotes and quotes, letters of support, staff testimonials, and there's nothing that can replace the value of letters that capture both the essence of child life work, the impact of child life services for patients and families, but also how it changes the psychosocial experience, if you will. When staff write letters of support, it brings together that amazing combination of how did this change my workflow, and how also did our collaboration influence and impact positively the experience for the patient and family. And absolutely, these types of letters and pieces of support will always remain important when we are looking at understanding our programs, both the successes of our programs and where we would like to go in the future. In addition, historically, child life program leaders have been using different published research, certainly, but also the AAP statement on child life services. And many of us are familiar with the content of that statement, specifically the recommended staffing ratio of 15 patients to 1 child life specialist. And that is a recommended ratio and certainly adjusted based on patient acuity as well as the location of where the services are being received. While the statement is very strong and has really done so much for the advancement of the child life profession historically, we are learning from our AAP colleagues that in order for us to continue to have some type of a ratio embedded in this statement, we need to engage in systematic gathering of data to be able to bring together what we know through evidence-based practice, but also then a ratio backed up by a data collection process. The other piece of what we've done in the past is work together collaboratively to try to understand what does data collection look like for the child life profession. And so the patient ratio task force worked from 2010 until 2014 on that very effort. What do our peer colleagues and health systems do? How do they collect information? And what information is important to them? And on this slide, you can tell that there are a number of variables that hospital systems, hospitals in general, even different workforce in the hospital collect data around. Is it outpatient days? What type of information goes into a ratio? Sometimes in the world of finance, you might be familiar and hear the term, are we looking at adjusted patient days, to try to inform how many staff do you really need to have in the building on any given day to take care of any given patient? Is it based on a census? What kinds of elements are important to understand? Productivity. And of course, this slide has many different variables or terms on it. Inpatient days stands out very much. And what we learned certainly in all of the preliminary work done through the task force and through our subcommittee's work is that there's such variability in what we collect across institutions that in order for the child life profession to be successful, we needed to come to an agreement as to what could we collect that would best reflect child life practice, in addition to being able to speak to the language of finance and budgeting that happens in our healthcare systems. And so what you're going to learn about throughout the course of this webinar is exactly what we were able to agree on, almost our lowest common denominator that would translate across all different types of child life programs, whether it's a 1-person program, a 5-person program, or a 65-person program. And so by finding that common language, we could tell our story for the very first time with big data, profession-wide data. Again, the one other thing that we'd like to share with you throughout on this slide for the webinar is to understand another effort that the subcommittees did together to make sure that we were actually collecting data that was important to child life leaders to be able to advance their programs in their institutions. And so a Survey Monkey was developed and sent out through the Program Leader Listserv in the fall of 2016. And the question was asked, what data is important to you? And on the left side of the chart, you can see that there were a number of areas that were important to find out, be able to get a ranking. If we were going to collect data, where should the focus be? Whether should it be data around patient satisfaction variables? Is it to improve the experience of care or help to save money in the institution in workflow areas? And there were 3 categories that surfaced to the top through the process of the Survey Monkey. Number 1, the top area that child life program leaders care about the most right now is to be able to understand the productivity level of child life specialists. Actually, how many patients can a child life specialist serve at any given day at any type of shift? The second area that was extremely important to child life leaders, and certainly not very far behind the first category of productivity, is the area around utilization of resources. How do programs make decisions based on staffing levels, staffing hours, how many days is a program staffing a playroom or different types of services that are offered? What types of elements are part of a child life program? And are there best practices around these different programmatic elements? And how do we actually figure out how to communicate around that type of data? The third component that was almost equally important as utilization of best practices is this notion of, can child life services, the impact of child life services, actually improve patient outcomes? And we're looking at a wide range of outcomes when we consider this element. It can be anything from improving throughput to your radiology area to improving topics around patient safety. So for the purpose of the benchmarking platform, the subcommittees considered these 3 data areas to help drive how we develop the survey questions. Now I'm going to turn the webinar over to Kate and the next series of slides.
So Patrice set us up really well to talk about what metric really is important to us and how do we capture our story and our impact within hospitals in a way that's clear, concise, easy to tell, but also meaningful for us as programs. So what we did was let the evidence guide us toward really showing the impact of our outcomes. We had our subcommittees looking at all of the existing published literature related to child life and psychosocial interventions for children within hospitals. And what we found is that the outcomes from the published literature really supports the idea and notion that with psychosocial support from child life specialists, we can expect to see better coping, less sedation use, increased patient-family satisfaction, better communication between families and amongst the medical team, and many more. What was distinct in the literature that was published was that there were 6 primary areas where child life specialists provided services that had the biggest and most pronounced outcome from a positive manner. That included the inpatient acute care areas, whether that be a general med-surg floor or a diagnosis-specific type of unit like an oncology unit. It also included critical care, radiology, pre-surgery, outpatient ambulatory care, and the emergency department. And these are not surprising from a published literature standpoint because these are the areas where we most often are staffing and providing support. Using these 6 areas as the basis for what we're calling the capacity for patient-family care, basically our data boils down to a simple equation. The number of patients and families encounters, or the number of opportunities for positive outcome provided by a child life specialist in a day, divided by the total length of their scheduled shift. What that allows us to do is tell a very clear story to each other about our programs and to our administration, and more globally about our profession, to explain what the true impact of child life specialists can have on a system in any given day in any one of these areas. So our new building blocks are much simpler than the building blocks we've used to collect data in the past, really because we're boiling something down to just a few areas where we know impact is most important, and to really describe the work that we are doing every day within the healthcare environment. So our building blocks look at the number of patient families seen, or what we're calling the patient family encounter, and then the 6 areas where our evidence is the strongest to show the positive outcome we can have when we interact with patients and families. At every different hospital, we have units that are classified in similar or different ways. And as a caveat to that, we do want to give everyone the opportunity to review the slide so that they know where a particular unit that they're providing services might fit. So for example, you might have an observation unit at your hospital that you're not sure how that's classified. In some cases, a hospital would classify that as inpatient, and in others that might be part of your emergency department or even your outpatient ambulatory services. If you're unsure of where a particular unit or area of service that you provide child life support falls under, we're recommending that you refer to your institution to define the area, and you'll define it based on how you list it for both your accreditation bodies like the Joint Commission or for CMS. What the capacity for patient family impact allows us to do is finally get to that apples to apples comparison unit, because we're very clearly defining what a patient family encounter is and very clearly defining what the length of time for which we're providing those encounters is. So it really lets us look at a comparison not just of apples to apples, but really type of apple to type of apple, like Red Delicious or Gala. It's giving you the opportunity to look at services specific to where you're providing the intervention. So the first thing that people are going to do at their individual sites is record the length of a scheduled shift for which their clinician is working based on their area of assignment. So for example, you might have a staff member who works regularly an 8-hour shift within the pre-operative surgical area. They would record 8 hours as the length of their shift, and they would record pre-surgery as the area in which they were seeing patients. What this allows us to do is record the entire length of the shift versus the time that was specifically spent interacting with patients and families. And the choice was made very deliberately to record the entire length of a clinician's shift, knowing that not every minute of every day is spent directly with patients and families. There are many things that we encounter in our lives as child life specialists, even outside of the world of administration or program leading, things that clinicians do every day that takes them away from the bedside. These things include orienting volunteers, cleaning toys, managing and stocking supplies, accepting and sorting through donations, attending mandatory in-services or meetings, and precepting interns and new employees. All of those things are necessary parts of our daily work and parts of our jobs that we have to do in order to maintain operations and standards within the hospital. And we wanted to make sure that was accounted for in any type of capacity for patient family calculation, because without those things, our programs will not continue to run. So by using the standard shift of their full scheduled shift of perhaps 8 hours or a 12-hour day, what we're doing is noting how many patients and families you can impact in a day while maintaining all of the other components of the work. It also makes for easier data collection, and often as a program leader, we have access to the scheduled shift, and that's not going to be a necessary piece of information for a clinician to record every day, because you may be able to access the scheduled shift via a system that keeps your time. The next piece that we have everyone collecting at their site is called the patient encounter. And what that is a total count of patient-family interactions that a child life specialist is completing on any given shift. We're considering a total number of patients seen to include any interaction with a patient, sibling, or primary caregiver when a child life specialist interacts with them in a way where they're providing child life services. There are a few examples I want to share that can help clarify exactly what counts as a patient-family encounter. And then you'll also find a linked FAQ sheet, which walks through a number of scenarios that you might have questions about and how to count them. One circumstance that's important to note is that child life specialists might work with one patient on multiple occasions during a day. However, if those occasions are tied to the same patient with the same MRN, it would just be counted as one encounter for that patient and family. And I'll walk through an example in just a moment. However, there are going to be situations that arise in a day where a child life specialist might work with multiple patients who actually are related. This could be in the case of a sibling transplant where the sibling, who's both the donor and the recipient, are inpatient at the hospital at the same time and would have two separate MRNs associated, so therefore the child life specialist would be documenting in two places. This is one of the rare occasions where one family might count as two encounters. Another piece to note is that if there's a child life specialist who sees a patient and family during the day, they would count that as an encounter. However, you might have a different child life specialist see that same patient and family in the evening. They also would count it as one patient-family encounter. When we're talking about the capacity for patient-family impact, what we're really trying to measure is the number of patients and families that one particular child life specialist could impact across their scheduled shift. So if each child life specialist saw the same family, they would each get to count that as an encounter. Here's a better opportunity to display what it would look like if a child life specialist saw the same family multiple times. So of course, this is the Hospital for Snowman, where Olaf and his family are receiving treatment, and Belle is one of our child life specialists there. Some days Belle will see the same patient, Olaf, and his family multiple times. So for example, Belle might see Olaf in the morning, she might see Olaf and his mom in the afternoon, and she might see the whole family later that day after school. Because her impact is to just one patient's family with just one associated MRN, she would count this as just one patient-family encounter for the day. We know that everyone staffs their program in different ways, and so we've come up with a little bit of a shorthand to help you divide out your encounters and your time appropriately. In many cases, a child life specialist is assigned to a designated area or unit of support. If that's the case at your institution, almost always that specialist will record all of their encounters and their entire scheduled shift in the same area of coverage every time. So for example, you might have a child life specialist who works in a primary unit. There are going to be occasions at your site where that specialist might get called off their unit to provide support in a different area, or they might be the consult person for the day and generally would get one or two consults to another area. If they are spending 80% or more of their targeted time on their primary unit, then even if they saw a patient in another area, they would still count that in their primary bucket of encounters, as well as the length of their full shift under that primary encounter area as well. However, there are many hospitals where a specialist splits their time regularly and scheduled across multiple units. This might be in the case of a float child life specialist or someone who evenly splits their time. For example, you may have a child life specialist who splits their time between an outpatient oncology clinic and an inpatient oncology unit. What you would do in that case is divide their time equally across the areas in which they're working, in the case of a float specialist, or consistently divide the time that they spend regularly in each one of those areas. So for example, you might have the specialist who works 30% of their time in the outpatient oncology setting and 70% in the inpatient area. Every day, they would standardly divide their scheduled shift across these multiple areas and then count the number of patient encounters in each area in particular and record that in the associated area. Here's an example of what that might look like. So for example, Cinderella works an 8-hour shift in an acute care inpatient setting. Usually all of her encounters are scheduled, are recorded in the acute care area, and all of her scheduled hours would be in the acute care bucket. However, Cinderella is covering the emergency department as the consult pager holder this week, and she gets called to see one patient in the emergency department. Because that one patient comprised of less time than 20% of her day, she would have spent 80% of more of her time in the acute care area, and she would record that encounter. Though she saw the patient in the ED, it would still fall in the acute care bucket. Subsequently, Belle also works at her hospital, but is a float position. That means every day she is in charge of covering 3 particular areas: radiology, acute care, and critical care, and she spends equal time in each one of those areas. She would divide the length of her scheduled shift, 8 hours, in 3 and record both time and encounters across these 3 areas. So at the end of her shift, she would have 3 different areas where she was recording encounters and time. There's going to be variation in the data you collect at your site, and we want you to understand that that's okay. There might be time when your specialists are very, very busy, and we know that that's seasonal, right? So the example I give, if you've got the Easter Bunny coming to your hospital and you are having to pass out Easter baskets to each one of your patients' rooms, you might see 30 patients that day and have 30 patient encounters listed, which is probably not the normal number of patients you would see in every day. So there are going to be opportunities when the data collected by your hospital or by that particular clinician happens to be very high. There are also going to be days where your patient-family encounters are very low, and that can be for a number of different reasons as well. Perhaps it's a day where you have half a day's worth of CPR training and you're off the unit for a given amount of time, or you've got required training, or a weather-related incident. So I know in some places, whenever it snows or there's heavy rain, a number of patients and families don't end up showing up at the hospital. Like at my site, when it's a heavy rain day, our outpatient clinics are very, very slow with many cancellations because people don't like to come out in the rain. So that might be a circumstance that's unusual, but your child life specialist could have a much lower number of patient-family encounters on that particular day. We know there's going to be incredible variation, but there's also going to be a pattern to most of the work that's done by our child life specialists. And we expect, as we collect this data over time, that we'll start to see what that pattern is, and our high days and our low days will begin to even out. We're also going to look at the median of data as we collect this data from programs across the country, because looking at the median for the capacity of patient-family impact really allows us to see what's most common for the practice of a child life specialist, and what's the most common expectation that you could find when looking at the impact. When we put everyone's data together, we might expect to see some programs lower than others, many falling into a mid-range, and many in the high range. And it's okay to feel a little bit nervous about what those numbers might look like. But one word of advice I have, and one thing that this Child Life Professional Data Center allows us to do, is really hone in on comparing our data to programs that are like ours. So even if you find that your capacity for patient-family impact is lower than you would have expected, oftentimes there's a more complex story that we can tell about our program that relates to why that impact would be lower. So for example, if you are a program that manages all of your donations, volunteer orientations, and many other administrative and organizational components on a clinical level, you might expect your patient-family impact to be less than a program who has administrative support to help with those pieces. That's not saying that you aren't making an impact. It's just saying there's more complexity to the story than always meets the eye. And the Child Life Professional Data Center will allow us to sift through that data to be able to compare yourself to programs that are most like yours to get the most accurate comparison. Patrice is going to talk to you a little bit more about some different ways that you can collect the data at your site to make it easy to both put together and be able to report on a quarterly basis. So back to you, Patrice.
Thank you, Kate. We recognized that there's probably programs that maybe are not collecting this type of data to date. And we wanted to provide some examples, templates, if you will, of what maybe would work for you to get you started collecting the data. So I'm going to walk you through both an example using a Word document and an Excel spreadsheet. So the example for the Word document is fairly straightforward. We're calling it the Daily Productivity Data Collection Tool. And for the purpose of the example, we have included all of the different buckets or areas, if you will, of where the database is accepting productivity data. And so the list is there: inpatient acute care, critical care, radiology, pre-surg, ambulatory, and then emergency department center. So using the example, if the person is assigned to one area and that is where they spend 80% or more of their day, the staff's name would of course go in the name spot, the date that the recording the data. In theory, if you were using the paper-based method, you could either save it on the computer and enter it that way, computerized, or print it out, and then the child life specialist would be writing on a piece of paper every day. And so if you are assigned to that one acute care med-surg unit, for example, the only place then that the person would be filling out productivity data would be in that first area on top, the inpatient acute care, where they would be recording the number of scheduled hours worked, as well as the number of patient encounters. If you were to adopt this method, and the person was always going to be working in acute care, feel free to delete the other areas off of the form. The form would work well for a program where there is a float position, or if staffing is such that every day when someone comes to work, they could be covering multiple areas, thus recording scheduled hours and patient encounters in multiple different buckets. And so this type of form certainly would accommodate that type of daily practice. The next example is to help the program leader or child life specialist who is going to be responsible for collapsing or adding up the data on the local level, to give you an example of what that might look like. So the productivity data will be, one number will be entered into the database to reflect number of scheduled hours worked, say in the inpatient acute care bucket, for the quarter January, February, March. So we've given you this example. You can circle the quarter at the top to help keep yourself organized. So really what will happen then is, I'll give you an example. I have 3 staff and they work on 3 different acute care units, and that is where they spend 80% or more of their day. And so person number 1 will have collected a local productivity sheet for every day worked in January, February, or March. So I would sit down at my desk when I want to add up the numbers, and I would look at person number 1's pieces of paper and actually total all of their scheduled hours worked and all of their patient encounters to come up with a sum for that employee A. I would do the same process for employee B and employee C, and then I would total A, B, and C scheduled hours and A, B, and C's patient encounters, and put that cumulative total on the lines indicated for inpatient acute. Once I go to the database, I would then have my finite number that I would put into the platform. And so you would carry forth that same example for the bucket of critical care, radiology, pre-surg, outpatient ambulatory, and outpatient emergency department. Some programs are very comfortable with using Excel as a tool to collect and then also sum numbers in general, but productivity data for the purpose of this example. And so we created a workbook that would be used for one child life specialist to record an entire year's worth of productivity data, each tab reflecting a different month in the calendar year. This example is for August. And so just as I described the employee counting how many encounters for the first of the month, which would be August 1st, then the total encounters would go in cell B5. And the total time spent on that inpatient unit, the scheduled shift, would go in cell B6. The ease of using Excel is that at the right of this spreadsheet, after we get to 31 days in the month, you could have it be an auto sum and auto calculate the total acute care encounters or radiology encounters for the month of August. We also included a tab at the end of the 12 months for the tabs in this workbook to be the summary for quarterly data collection. And in our example, I will be clear that we did not embed calculations, so it pulled summed data from each one of the months. You would actually have to do that by clicking between the tabs. But this is it gives a great example of where you would you could log all of the January totals, February and March, and of course then summing it for the quarter in column H. If you are very comfortable using Excel, or you have people in your setting who could help you with this, you could have them create a workbook per staff member, and then in addition, collapsing data into one workbook for the quarterly sum. But those, of course, are ideas for those of you who are very comfortable with formulas and working in Excel. We have included specific instructions for both the child life specialist as well as the program leader who will be collapsing data for the ease of use of understanding how to use those forms. Basically, these next two slides are a summary of what I've just shared with you when we were looking at the examples. So we did touch a bit in the objectives for the webinar on this notion of how do we support our staff through change. And an example of which you might want to utilize is to capture on the popular movie Inside Out. I think we're all familiar with the different characters and emotions, and certainly this is a great way to normalize the wide range of feelings people have during a change and the implementation of new expectations, and specifically around this idea of productivity.
So now if you may be feeling overwhelmed with information and sort of the next steps that you'll need to take at your site. So we want to incentivize this a little bit by sharing a sneak preview of what the Child Life Professional Data Center looks like and what it can be doing for you as a program leader to help you advocate on behalf of your team. We have two areas within the Professional Data Center that I'll talk about, but I wanted to give you a little bit of background about how this was created and how it came about. We've tried very hard in the past to use homegrown methods to be able to look at data collection, like our complex Excel spreadsheets and data that's been collected in the past. We're so pleased that ACLP took both the time, initiative, and support to be able to help us work with an outside vendor to create the Professional Data Center and what it is today, and what we find will be an incredible useful tool in the future for our profession. The ACLP dedicated both the time, resources, and money to create this website, and we've been able to work on it since September with a group called Dynamic Benchmarking to help build a robust platform that does a lot of things for us. One, it helps us look at our programs and be able to organize our data in a way that is very clear and easy to understand. It also lets us analyze in a robust manner through personalized filters and reports to see and compare our own programs to like programs around the country. I will add that while the ACLP was able to sponsor and support the initial build of this data center, there will be an ongoing need to maintain it and add additional variables in the future. And with that, there may be an opportunity and a need to have a yearly subscription fee for the most robust analytics that are involved in this website. But at this time, everyone will be able to access the website, and everyone, even outside of subscription fee, will always have access to the most basic information put in here. We spent the last 30 minutes talking about the quarterly metrics, which are entered for the first time this upcoming July. However, there are a number of annual metrics which we haven't touched on that we think will be incredibly useful to you as a program leader, and for which we're regularly seeking information both by calling and emailing our Child Life program leader, friends and colleagues, and then also posting on the forum for quick benchmarking data. All of that information will be accessible to you through the annual metrics, which you'll enter once a year in April. This will also stay open throughout the year so that if your program or hospital profile change significantly, you'll be able to update it. The annual metrics include things like information about your type of hospital. Is it a freestanding children's hospital? Is it a community hospital? Is it a hospital within a hospital? And what types of medical services you provide, like the level of care being provided in your emergency department or subspecialty services that are provided to your patients and families. Putting in the profile data related to your hospital or medical center allows filterable options so that you can create a peer group that's most like yours when you're comparing your data. The annual metrics then get more specific to the types of programs and services you provide to patients and families related to child life and complementary professions. So you'll be able to put in information about the type of child life services you in particular provide in your program, including the hours per day provided of services, the staffing layout of your teams, and specialty services that you might provide, like sibling center support, or complementary therapies like music therapy, art therapy, and others. You'll be able to put in all types of program information under the Programs tab. You'll also be able to put in budget and finance information. So you'll be able to break down the budget that you use at your site to pay for not only staffing, but also operational components of your program, and also to pay for services and support outside of child life specialists. So for example, if you provide facility dogs or clown care program, you'll be able to put down information about those programs in particular to be able to compare with your peer group. We also ask questions about the professional staffing of your programs, select positions, and details related to the positions and services providing. Again, to be able to give you opportunities to both compare yourselves through reports and also be able to build your own peer group with as much or as little specificity as you'd like. Everything that you see that I've talked about in both the annual and quarterly metrics will be easy to collect because we'll give you a quick capture guide via Excel that lists every metric that you'll need to enter into the data center. You'll be able to use that quick capture Excel sheet both to fill in your data ahead of time and to share that with people who might be helping you pull the data from your particular site. For example, you might consult with a business manager related to your budget or related to the metrics for your hospital profile. Where it gets really cool is the ability to compare data and run reports. So this is something we've never been able to do before as a child life profession, and the CLPDC allows us to have full and robust analytics to compare our programs. What you see on your screen here is a set of filters, ways that you can be able to slice and dice the data to be able to see a peer group that's most like yours, to be able to provide an annual report that gives you data compared to other programs. The data is also already analyzed for you, so you can download your report as either a PDF, a PowerPoint, a Word document, or an Excel document. All of those will be professionally packaged to make it easy for you to tell your analytics story, both to your team and your administration. These are some examples of both quarterly data and annual data that you could run reports on. So for example, on the right-hand side of the screen, you could look at program staffing during weekdays and weekends, program staffing hours around the clock, and hours per FTE. These are all questions that regularly come up on our Directors Forum that you'll be able to access in real time without having to wait at the mercy of responses from your peers. On the left-hand side of the screen are quarterly indicators, which you'll be able to run reports on, specifically related to the capacity of patient-family impact in each of the 6 areas that we've discussed previously. The timeline for all of this is happening so quickly, it's exciting to share. So the Child Life Professional Data Center is going to officially launch April 1st and will be available for you to enter data in at that time. Beginning in July, the Filters and Reports tab will also be going live, and you'll be able to look at reports that you are able to customize for yourself. The first quarterly data is entered in July for the April through June time period, and reports from a quarterly perspective will be available in October. The quarterly reporting window is different a little bit than the annual window. Annually, you'll be able to adjust your data. However, quarterly, you'll only have 2 months from the end of that quarter to enter data. That's because we'll regularly be entering quarterly data, so if we let that go on forever, the reporting periods could get confused. Starting July 1st, the first quarterly productivity data will go in, and then the quarterly data cycle will open every 3 months after that. You can expect to be able to access filters and reports 3 months after each of these quarterly cycles. Next steps related to this program in the Child Life Professional Data Center are that starting April 3rd, you'll get access to be able to log into the CLPDC via the ACLP website. You'll be able to get familiar with the sections and survey questions we're asking, and also begin to input your data at any point after that. There are many supporting documents located within the CLPDC landing page, and so you can access those to help answer questions. Anything that we're not able to find via the FAQs, you can also contact the ACLP at the data center at childlife.org to join a peer group that will be able to give you access to a live peer who's been working in this process and can help answer individual questions or concerns that you may have. As we get closer to the opportunity to share and comparison and report options within the CLPDC, we will also be offering future webinars and teaching opportunities so that you can learn how to use the robust analytics of this platform. We appreciate you joining us today, and we really look forward to the amazing opportunity that the ACLP has offered us through this professional data center. Special thanks to the many who've been involved in this, including the Patient Ratio Task Force, the SAPP, and all of the subcommittees working within that group. Thank you, and we really hope that you enjoy this platform as much as we do.